I've been given the opportunity to talk about a year in review about clear cell renal cancer, particularly around advanced disease, which I'm going to focus on. I'm Tom Powles. I'm Director of Bart's Cancer Centre. I will talk very briefly, if I may, for a couple of minutes about the adjuvant space. I think it is really important. We saw an extraordinary array of data at ESMO 2022, which was presented by a number of different investigators. We saw the previous year and this updated analysis for pembrolizumab versus placebo, which essentially showed a 37% reduction in the risk of progression of disease-free survival in the adjuvant setting. This is a positive randomized phase 3. We also saw approximately a 50% reduction in the risk of death, early analysis, immature analysis. And this is with a 10% chance of life-changing toxicity, diabetes, pneumonitis, liver changes. So this is a very positive trial. It's got EMA and FDA approval. This data is consistent. And if anything, the numbers are getting better, not worse, Neil. I think they're the same, actually. But it then came as a surprise to us seeing published in The Lancet a negative atezolizumab study with almost identical design. Now, the conclusion may be that PD-L1 is less active than PD-1 in this setting. And I'm happy to have that discussion. Nevertheless, we know atezolizumab has response rates. In fact, it has CR rates of 11% in PD-L1 positive first-line disease. So atezo does have activity in this space. And then we saw a negative Ipi-Nivo trial, which was a real surprise. And indeed, we've written discussions and editorials around why that might be the case. Why would an Ipi-Nivo trial be negative if a pembro trial was positive? Because in advanced disease, we think Ipi-Nivo is at least as active as pembrolizumab plus lenvatinib. So single agent pembrolizumab should be, inferior, I guess, to Ipi-Nivo. What may be the explanations? Well, we did see more toxicity for the combination. And actually, we know patients in the adjuvant setting are less tolerant of toxicity. So that might be an important driver. The second issue is only 6 months of therapy was given in this setting rather than a year. And that's relevant. And Ipi was given 6 weekly rather than 3 weekly, as in the pivotal trials. So different regime, different duration, more toxicity, and this may all have contributed. Nevertheless, we still would have expected the curves to go apart a little bit. And we didn't see that, and so therefore we have to question the role of CTLA-4 in this setting. Is CTLA-4 doing anything? Is the Ipi helping at all? I don't think it is helping, otherwise we'd have expected the curves to go apart. And then provocatively, we need to think about things like, is pembrolizumab, why is that performing so well where other drugs are struggling? And I think there are two really important trials we need to see in the future. The first is there's a third arm of the Ipi-Nivo trial, which looks at single agent Nivo, and that will clear up the Nivo question. And then, of course, the second really important trial, the 8x8 study, comparing Ipi-Nivo with Nivo in the advanced disease setting, which will tell us what the contribution of Ipi is in advanced disease.
So one question about the use of pembrolizumab in the adjuvant setting. What is your bar to use the drug? I think the way it's approved was kind of based on entry criteria to the study, I think. But I guess my question is, would you expect benefit for patients who are at lower risk? And do you offer it to patients? Who do you offer it to?
So I just offer it to patients who completed the inclusion criteria of the study. The majority of patients in the study were intermediate risk. There was an M1 NED population, those patients that had metastasis removed. It was only 6% of patients, so the benefit was irrespective of that. And then I think the third point is that when we look in detail at those subgroups, there were benefits across all 3 subgroups. Now, that includes T2, G3, and 4. It includes T3, T4, N1, and that population we're offering therapy to.
Do you think that patients who are at lower risk would benefit from the drug?
I'm not offering lower risk patients the drug. and I'm not offering papillary cancer patients the drug. And I'm not super keen in going into this lower population. You know, the risk of life-changing toxicity is about 10%. And when you look at that, and then you look at the risk of relapse being low, you know, the benefit-risk ratio then becomes pretty grey. I think you're entering into really dangerous territory in that population.
So the next paper we were curious whether you had any thoughts on is the ASCO guideline for metastatic renal cell. I don't know if anything you want to say about that, whether that lines up with how you approach the disease.
So I phoned Kim. We had a conversation. I'm involved in the ESMO guidelines, which are different from that, and we are pulling together those guidelines. We've gone in slightly different directions. We don't believe that a tissue biopsy is in these guidelines. That there is a fair feeling that we should always be biopsying new stages of treatment. We feel that relapse within 2 years of the primary tumor in areas consistent with advanced kidney cancer is enough. And the reason why that's the case is it can sometimes be very difficult to biopsy small lung lesions. And it can be difficult to go in and do biopsies. And in fact, it can take a long time to do that. And it can put patients in harm's way. So we believe that biopsy is essential at baseline. And it's important for late relapse. But not all patients need a biopsy. We agree that cytoreductive nephrectomy may be offered in select patients with intermediate risk disease, but as a rule, nephrectomy and the role of nephrectomy is relatively small. We agree that surveillance after nephrectomy is potentially attractive for some patients. We also agree that patients with favorable risk disease, these patients, as we described before, the favorable risk patients, VEGF-TKI-IO combination is the standard treatment, but we actually are more liberal now around the role of sunitinib in these patients. And that, I think, is what the last point is also saying, is in some patients, monotherapy with VEGF-TKI is an option. We're not supporting monotherapy immune checkpoint inhibition in any patients. We've not seen data to support monotherapy. So for immune therapy, it's ipi/nivo for those patients with poor performance status or other comorbidities. Single agent VEGF-TKI therapy is relevant. We're no longer recommending IL-2. I think there was that recent randomized phase 3 with pegylated IL-2 versus sunitinib, which was the first negative randomized phase 3 trial that we've had. And so that, for me, turns me off single agent VEGF-TKI and turns me off on IL-2 on both of those. So we're avoiding those therapies. On the whole, more similarities than differences between the United States and Europe. I think we're probably slightly more restrictive and we're doing less interventional biopsies. Some updates from some of the pivotal trials around advanced disease. And it's fair to say that every year, 2 or 3 of the trials are updated. We've got into the habit of looking at the latest data cut from the 4 practice-changing data sets. One of those 4 data sets is the Cabo-Nivo data set. But it would be fair to also say there's Len-Pen and axi-pembrolizumab as well as ipi/nivo, which are all essentially interchangeable in intermediate or poor risk disease. The good risk space is complicated, and I am going to talk a little bit about that today. I'm going to talk about the update of Checkmate 9ER that was presented at GU ASCO in 2023, just recently. Essentially, Cabo-Nivo continues to outperform sunitinib, as you'd expect. The PFS of these data sets never changes very much. This is a hazard ratio of 0.58. All of the VEGF-TKIs outperform sunitinib significantly in this environment. Lenvatinib and pembrolizumab is the most successful at that. That's hazard ratio about 0.45. Here you've got a hazard ratio of about 0.6. But we also have this significant overall survival signal. And with this later data cut of over 40 months, getting towards 4 years, it's 44 months, just shy of 4 years, we can see a significant benefit. These consistent benefits are seen across all of the trials. Now, there's a debate about whether or not one trial is better than another, one combination is better than another. But this cross-trial comparison is flawed because all of the control arms perform slightly differently in each of these trials, and indeed, access to subsequent therapy is slightly different in each of these trials, all of which will affect overall survival. Actually, when you look at the detail of this, they're all coming in at very similar points for the intermediate and poorest population. And therefore, it remains the case that these four combinations are largely interchangeable in intermediate and poorest disease. The one outstanding issue is around the favourable risk population. Axitinib and pembrolizumab, when it was first released, its first data cut, with only 12 months of follow-up, showed benefit across the board, favourable, intermediate and poor risk. And that resulted in not only a broad label, but broad guidance approval, so ESMO guidance, NCCN guidance, ASCO guidance, approved in intermediate and poor risk patients with level 1A evidence. You can see from here the overall survival benefit in the favourable risk patients is not convincing. And indeed, as time goes by, for this combination, but also axi-pembro, and also lenvatinib and pembrolizumab, the hazard ratio in the favourable risk population remains at about 1. While the response rate for the combination is higher than sunitinib, and the PFS for the combination is significantly better than sunitinib, there is uncertainty about this survival signal. And actually, we're having a bit of a discussion in the academic community about whether you have to give the combinations or it's acceptable to give single agent sunitinib. We move on to an update for the CLEAR trial. This is the most recent combination to come out of lenvatinib and pembrolizumab. Again, progression-free survival was the primary endpoint. This most recent data cut shows us data with a slightly shorter follow-up, actually, than cabo-nivo and axi-pembro. Nevertheless, you can see the overall survival hazard ratio here, again, in the mid 0.7s, 0.72. Similar to what we saw previously, slightly shorter follow-up, you'll notice the control arm performing slightly better. This group had the highest proportion of good risk patients, and we know sunitinib performs best in this group. That's probably why the control arm is performing slightly better. I've not shown the progression-free survival or the response rate, but the response rate for this combination is in the high 70%, about 70% PFS and less than 0.5. But the overall survival signal remains very strong for all of these. Here is the PFS signal, which, as I said before, was perhaps the best PFS signal we've seen for any of these combinations. So I think that the conditional survival of ipi-nivo versus sunitinib, I think comes as no surprise. But what happens is for the winners with ipi-nivo, they go on and do very well. And that's true of the winners for all the VEGF TKI, all the PD-1 combinations. The most important thing that's happened in kidney cancer in the last 5 years is we've managed to essentially put a group of patients into long-term durable remission who appear not to relapse. And that's what we see from this paper. And that's probably about 20 or 30% of patients going into this durable remission. And we'll see from some of the PFS curves that remains to be the case. And indeed, in the most recent analysis, the 5-year survival of these patients is about 50%. And here you can see this survival analysis and the curves going apart and staying apart. The one point, Neil, I'd like to make here, if I may, and I've been making this for some time now, and I don't know how popular I am, but at 60 months, at 5 years, you can see the PFS for ipi-nivo is 30%. But that's not 30% of the ITT population. You can see the ITT population at about 600 patients, and 30% of that 600 patients would be 200 patients. But we've only got about 50 patients at that 3 months. So essentially, we've got quite a lot of heavy censoring on this curve. So although for those patients who remain on trial, which is only about 10% of patients, 30% of those are progression-free. But there are many patients who are being censored out before. That doesn't mean the progression-free survival is not 30%. It doesn't mean it's 10%, but it means there's a lot of uncertainty because we're losing a lot of patients along the way. It could be higher than 30%, but it means there's uncertainty, and that's really important. This is a curve I've made myself. and I apologize for that. The triangles are ipilimumab and nivolumab, and the stars are VEGF TKI IO combinations. The green is cabo-nivo. The x-axis at the bottom is the time of follow-up, and the OS hazard ratio is on the y-axis. Each of these points is a data cut that we've seen. Each is a publication. You can see how many publications there have been. No wonder it's confusing. And the large green star right in the middle is the most recent data cut, which I just shown for cabo-nivo. And you can see here, actually, what the point this makes is that as time goes by for the VEGF TKI IO signal, the initial fantastic hazard ratios for survivals in the 0.4s and 0.5s have come to land in about the same place for the intermediate and poor risk population as the ipi-nivo population. Now, ipi-nivo has the longest follow-up. What does this mean? Well, it's very simple. It means the survival signal for all of these four combinations is about the same at the moment, and as time goes by, they seem to track each other. And therefore, when someone comes out and says this is clearly the best combination, or this has the best survival signal, or this has the best landmark, I'm not bought into that concept. I think we're showing about a 30% reduction in the risk for these combinations, for all of them, as time goes by, over sunitinib. The next important step in the first-line setting is the COSMIC 313 study. This study was a randomized phase 3 for cabo ipi-nivo versus ipi-nivo. It's in intermediate and poor risk patients with frontline clear cell renal cancer. The reason we pick that group of patients is that is the standard of care for ipi-nivo. We know this is a positive trial with a hazard ratio for disease-free survival of 0.73. Tony Choueiri presented that at ESMO. At ASCO GU, we saw a further update to this data. The update is important because the initial data was only on 550 patients. That was because it was a progression-free survival cohort. I'm now showing the overall survival cohort, which is 850 patients. It also has 5 extra months of follow-up. Here is the trial design. As I've said before, frontline clear cell renal cancer, intermediate and poor, triplet versus doublet therapy, progression-free survival, primary endpoint, overall survival, not yet hit and not yet shown. We can see here this PITT, the 550 patient population, has a hazard ratio of 0.74 with 5 extra months and 300 extra patients. That hazard ratio continues to be the same and continues to be meaningful. This underpins that particular endpoint of this trial, but as I said before, we haven't yet seen overall survival. One of the intriguing findings of the original data set was we showed a difference between the intermediate and the poor risk patient. The benefit was confined to the intermediate risk patients. It was unclear about why that might be the case. Initially, it might be because the trial is statistically not powered to show the difference, and it could have been by luck alone. And for that reason, we looked in this larger 800 patient population rather than just the 500 patient population. And guess what? The results seem consistent. It does appear most of the benefit, even with the longer follow-up and the larger numbers, is confined to the intermediate risk population. Why would that be the case? Well, one obvious reason would be it's hard to give a triplet to the poor risk patients. However, if you look here, the median duration of exposure to treatment is 11 months in the intermediate and 10 months in the poor risk group. So they're getting the same exposure of therapy. And actually, if you look at the average dose of carbo and the median number of infusions of immune therapy, it's exactly the same. So we were able to give the drugs to the poor risk patients, but they still did less well. And indeed, you can see the toxicity for poor and intermediate risk populations being approximately the same, with grade 3 related adverse events being similar in both groups. It's therefore fair to say we've seen this difference. It's not statistically powered to show a difference, but it is consistent in the bigger population. And it's not purely because we were unable to give the triplet. I wonder if the reason why this might be the case is because biologically there is a difference between the intermediate risk patients and the poor risk patients. We know the poorest patients are responsive to immune therapy and somewhat resistant to VEGF-targeted therapy, and that may account for the difference. Neil, I think you've got a question.
So yeah, frankly, this whole area has always been confusing to me, and it's just getting a lot more confusing. So maybe you can straighten it out for me.
I
So
hope
let
so.
me just kind of go back a little bit in terms of risk status and benefit of treatment. So
Yes.
one thing that you have one algorithm that kind of relates to the risk assessment, but the other kind of algorithm I hear people talking about is just whether the patient's symptomatic and needs a response or not. From a clinical point of view, when you have a patient who's presenting for first line therapy, metastatic renal cell, from a clinical
Yeah.
point of view, one of the messages I get is if the patient doesn't need a response right away, they're not tremendously symptomatic, generally go with ipi-nivo. So that's kind of a clinical approach that's fairly easy to follow. But once you start getting into the risk thing, to me, it gets a lot more complicated. So maybe you can clarify it. So first of all, in the original ipi-nivo study, where there was no benefit in the favorable risk patients, was that a planned subset analysis? And was that statistically valid? And do you think that really is for real, that these people don't benefit?
So it is statistically valid because it was tested formally in a hierarchical analysis. It was a stratification factor. And so, yes, the answer is it was statistically valid at the initial data cut. I have to tell you, Neil, if you look at the overall survival signal of the most recent data cut, the hazard ratio is currently at about 1, it's 0.93. So ipi-nivo in the long term is not worse than sunitinib. They're about the same. And that has created some confusion. There is some elegant work by Brian Rennie and others looking at angiogenic signatures in clear cell renal cancer. And it showed the good risk patients have strong angiogenic signatures. And I think it's fair to say that the good risk patients appear to benefit the most from VEGF targeted therapy, and the poorest patients probably benefit the least from VEGF targeted therapy.
So are there patients with good risk disease that you use first line TKI?
Yes, yes, there are. And it's entirely reasonable approach. Now, I know there are other people who say, their only chance of long-term durable remission is with immune therapy, and therefore you have to give both. But the evidence at the moment doesn't support that. The Kaplan-Meier curve hazard ratios are 1.0 for all of the combinations. And so you have to have the eye of faith to feel that the immune therapy is changing the landscape in the long term. Now, it might be, Neil, the 10-year data, not 5-year, the 10-year data, because the median survival of this group has not yet been reached. It may be the 10-year data shows actually giving immune therapy up front was the right thing to do. But that requires the eye of faith. And at the moment, groups like the Swiss group and other groups are thinking about changing their guidelines to bring sunitinib or pazopanib back into that good risk population.
Interesting. And again, going back to the original ipi-nivo study, they did not see a benefit of response rate or PFS at all in favorable risk?
No, they did not. Sunitinib was significantly better.
Okay, so that's very helpful. And then the second thing is now you're starting to show data with IO TKI combinations showing a lack of benefit in the good risk patients. Again, I don't know if that statistically, okay. Was it planned subset analysis? Has that been seen with all the TKI IO combinations, or only the two that you were talking about?
So this is more exploratory and it's less statistically robust. The fact that the ipi-nivo data set a precedent and looked at this meant that we looked at it in all the subsequent studies as well, which seemed reasonable at the time. Had this only been seen in one of the 3 trials and the other 2 trials showed benefit, we probably would have said it was just a chance event. But because it's occurred consistently across 3 independent trials in exactly the same population, it's likely that this is not by luck alone. And indeed, a meta-analysis of those 3 trials will show a hazard ratio of 1.0 essentially. And so I think it's reasonable under those circumstances to say, although it wasn't predefined, and indeed the label allows you to give the doublet in this population, if a patient comes in and says, I don't want to have the immune therapy in the good risk population, they're not necessarily wrong.
So, yeah, just to pick up on that a little bit more. So, for example, I mean, when I think about good risk, the first thing that pops into my mind is somebody who's had a recurrence after nephrectomy, several years later. I don't know, is that a typical scenario where you see it?
Yes. Yes.
And so my question, if you have a patient like that and the patient is very symptomatic, so first of all, in general, would you be thinking about a TKI with that patient? And what about if the patient is symptomatic?
So there are 2 parts to that. I think when we look at good risk patients in today's environment, we should be thinking about essentially 3 questions. The first is, do they need systemic therapy? Yes or no? If the answer is no, they don't, can they get away with surveillance alone? Or can we ablate or use radiation therapy? So 2 small lung lesions, 1 centimeter, 5 years after nephrectomy, the likelihood is they could take another 3 years to grow to 2 centimeters. And if that were the case, do we need to intervene immediately? Probably not. Could we get away with surveillance? Yes, absolutely. Is radiation therapy or surgery or ablation reasonable? Yes, I think so. So I think that's the first question. Do they need systemic therapy? If the answer is no, there are other options available to them. And then which good risk patients really need systemic therapy? And that's a question which is, a question. If that patient came back a month later and suddenly there were 4 and not 2 lesions, you'd probably say, well, 4 lesions, not 2. We're growing. We're beginning to get into problems. We've got 4 lesions. The likelihood is this is out of control, in inverted commas. And then the issue is, how do we get back in control? Well, you'll get back in control pretty quickly with sunitinib. You'll get in control. You'll reverse that process. People like Mike Atkins will say, hold on a second, this patient's now on sunitinib for the rest of their life. And the answer is they probably would be. But there isn't evidence at the moment that immune therapy will put these patients into long-term durable remission that's better than sunitinib as it currently stands. Now, people like Brian Rennie will come back and say, but hold on a minute. If you're going to start something, at least give them a go with a therapy that may be associated with a durable remission in the long term. And we may even be able to stop the drugs 3 or 4 years down the line, and we're not there yet. And that is an entirely reasonable argument. Also, the response rate for Axi-Pembro is going to be more like 60 versus 30% for sunitinib. So the combination has a higher response rate. So it's reasonable to say we're going for a higher response, better PFS. That's why we're giving the VEGF combination. But in this space at the moment, it's entirely reasonable to give single agent VEGF TKI, VEGF TKI IO combinations, surveillance, radiofrequency ablation, or even radiation therapy.
That's really helpful. Thank you very much. Please continue.
I'm going to go into the second part of this story. We've talked about the first-line therapy. We now need to talk about biomarkers. And the reason we need to explore this field is I don't think we've been super good at biomarkers in kidney cancer. We all know in prostate cancer, there's really exciting data on PARP inhibition. In kidney cancer, in bladder cancer, there's data on PDL1, which is mixed, of course, but we've done lots of studies, also FGFR. But in kidney cancer, we've really struggled. And in fact, we use the IMDC classification still, which is not really a tissue-based biomarker, more a blood biomarker. Here, we're showing for the first time at ASCO GU23, biomarker analysis for the combination of VEGF TKI and PD-1 therapy. The story so far, which is basically derived from the bevacizumab atezolizumab and avelumab axitinib datasets, has showed immune interferon gamma signatures, T effector signatures, and CD8 are all associated with response to PDL1 therapy. Can we repeat similar experiments with Cabo-Nivo and come up with responses to PD-1 therapy. And here we can see a series of gene signatures. So this is RNA sequencing analysis, a series of gene signatures on the left-hand side associated with response with longer PFS to cabo-nivo. One of the intriguing issues is third down is an angiogenic signature. That's not a classic immune signature. And one might say, well, why is the angiogenic signature not coming up for sunitinib? That's an angiogenic drug. It may be that cabozantinib is a better angiogenic-driven therapy than sunitinib, because it's important to remember that this is not just driven by PD-1 therapy. The cabozantinib has an important role to play as well. But you can see down here the other red markers, those associated with classic response to the combination, are not those associated with immune signatures. So interferon gamma signatures, for example, are not popping out in the way one might expect. And indeed, we're seeing more hypoxia and angiogenic signatures. This is intriguing because it's suggesting there are distinct signatures for PD-1 versus PD-L1 therapy. And dare I say it, it may even be a marker of additivity or synergy for the angiogenic signatures associated with cabozantinib or versus sunitinib. Another biomarker which we've explored a lot with mixed results across a broad spectrum of cancers is PD-L1. We've seen this sort of data before, actually, with atezolizumab and bevacizumab. And what we actually see is for the immune combination, it doesn't seem to matter if you're PD-L1 high or not. But with sunitinib, with VEGF-TKI therapy, those PD-L1 positive patients are performing less well. What does that mean? Well, PD-L1 is a broad immune biomarker, and I think essentially what it's telling us is those PD-L1 positive tumors are the more immunogenic tumors. And as we said previously in this talk, we know those more immunogenic signatures respond better to immune therapy rather than VEGF-targeted therapy. And therefore, it should be no surprise that those patients with the more powerful immune signatures do less well with sunitinib. CD8 has also been shown previously to be relevant in this setting. And so we've measured CD8 and we've measured CD8 across broad spectrum of cancer types. We've looked at inflamed, cold and excluded phenotypes. And in a Cox proportional analysis, we've shown that CD8 and actually CD8 topology, where the CD8 cells stand, are neither prognostic nor predictive of outcomes to cabo-nivo. And again, this is surprising because it suggests to us that this biology may be distinct from that biology we've seen previously with PD-L1 inhibition. And then, of course, cabozantinib is a MET inhibitor. And here you can see MET expression. And in both groups, the cabo-nivo and sunitinib, high MET expression is associated with poor outcome, whereas low, a better outcome. What does that mean? Well, it means that this MET story for cabozantinib is probably less relevant than its VEGF story in terms of generating responses in clear cell kidney cancer. We now move away from first-line therapy and we move into the era of second-line therapy. This is important because there are some more trials coming out in the near future. CONTACT-3 is a study where we're looking at cabozantinib plus or minus atezolizumab after previous immune therapy. So this is sequencing immune therapy. But what I'm talking about today is the data to support VEGF-targeted therapy in individuals whose cancers have previously progressed on immune checkpoint inhibition. TiVo-3 is a study of 350 patients for patients who have failed at least 2 regimes, including a VEGF-targeted regime, but many of these patients had also progressed after an immune checkpoint inhibitors. It's comparing tivozanib and sorafenib in this setting. Tivozanib is quite a specific VEGF-TKI therapy. Here you can see a significant delay in progression-free survival with a hazard ratio of 0.73, a 20% improvement into progression-free survival. And indeed, in those prior checkpoint inhibitor subgroups, you can see the hazard ratio is about the same, irrespective of whether they had immune checkpoints or not. And what this means to us is sequencing VEGF targeted therapy remains important irrespective of whether patients have had prior immune checkpoint inhibition. It's worthwhile noting before we go on to Cabo Point that there was no survival benefit of tivozanib versus sorafenib, and indeed there's never been a survival benefit of one VEGF targeted therapy versus another VEGF targeted therapy. So from my perspective, I see them as largely interchangeable. Neil, question.
I'm curious whether or not you have tivozanib available to you, and how you find giving it. I hear people saying it's better tolerated than the other TKIs. Do you have any experience with it?
The answer is yes, it is available, and yes, it does seem well tolerated. You know, Neil, I suspect if tivozanib had been developed first and not sunitinib, it might be the drug we use most often. But most of us, I think, are comfortable with sunitinib, axitinib, and cabozantinib, and we've got used to using those drugs. The issue with tivozanib is in TiVo-1, the original trial, it was a frontline trial. It used sorafenib as the control arm, which was suboptimal. And it also, because it had a forced crossover in the sorafenib arm to get second-line tivozanib, it had a survival hazard ratio of 1.23, which meant that the FDA rejected it because it said, you've done a trial, but the survival signal doesn't look good. And therefore, TiVo-3 was an attempt to resurrect the drug a decade after the original sunitinib came out. And so, yes, it does look like a promising drug, but its development has been a bit tortuous. And for that reason, it's not widely used.
The thing that I was wondering about is I think that there's some studies looking at tivozanib with IO and whether or not maybe that kind of combination might be better tolerated than the existing, or maybe it's too late for something like that.
Well, there's a randomized phase 3 study called NTivo, which compares nivolumab and tivozanib versus cabozantinib, a standard of care, or tivozanib, I think it's tivozanib as the control arm, as the standard of care, to see if the combination can outperform a standard of care in this environment. So yes, there is ongoing randomized phase 3 tivozanib trials for individuals who have previously, whose cancers have progressed on immune checkpoint inhibition. So it's not the most widely used drug, but it is going through a form of revival, and there are ongoing randomized phase 3 trials.
Please continue.
Cabo Point was another study presented at ASCO GU 2023. It's a study which is actually very simple in design. It's for those patients whose cancers have progressed after immune checkpoint inhibition, either alone or with VEGF targeted therapy. We know from previous trials, such as Meteor, that cabozantinib is active after VEGF TKI therapy, and cabozantinib has a survival benefit compared to everolimus in VEGF refractory disease. The question is, does it maintain response rates in individuals whose cancers have progressed after immune checkpoint inhibition? And you can see the design of this trial, cohort A and cohort B, patients who have progressed after immune doublets or VEGF TKI immune therapy. And the key endpoints are response rates. And here you can see the overall response rate of 30%, and it doesn't seem to matter whether or not patients have had immune checkpoint inhibition previously or not. Overall, it's fair to say that the response rates of 30% appear not that different from what we've seen with prospective series with pazopanib, prospective series with axitinib, and prospective series with sunitinib. And therefore, this is a drug which reinforces the importance of sequencing therapy, but does not necessarily mean cabozantinib is the most active agent in this setting. Indeed, subgroup analysis for this trial shows it working with similar response rates across broad subgroups of patients. Perhaps a more provocative trial is a study looking at belzutifan in combination with cabozantinib. This is an important study. The reason why it's relevant is this doublet looks a promising doublet in this disease. And you can see here, this is a study looking at patients who have received prior immune checkpoint inhibition and less than or equal to 2 lines of therapy. And we can see good responses from baseline, active responses, high response rates, which I think is attractive. You can see the adverse event profile in line with what one would expect. Grade 3 or more treatment-related events, 37%. So the combination becomes more challenging. Belzutifan is a new agent. We are using it more and more in kidney cancer. It's a HIF2 alpha transcription factor. As a single agent, it has response rates of about 25%. Perhaps the most attractive component of this drug is it appears to combine well with therapy. And I think this is important because we now have randomized trials of Pembro and Belzutifan in the adjuvant setting. We have randomized trials of lenvatinib, pembrolizumab, Belzutifan in the frontline setting. And we also have randomized trials of Belzutifan in combination in immune refractory disease, second line in the advanced setting. So Belzutifan is being actively pursued in at least 3 big randomized phase 3 studies. I'm going to shift gear, if I may, to the last important topic. The reason this is important is papillary kidney cancer has been to some extent left behind. The reason why that's the case is we, in the kidney cancer community, have just used the drugs that we've been testing in clear cell kidney cancer and adopted them in papillary renal cancer. But papillary renal cancer is not a strongly VEGF-driven tumour. And it's also not a strongly immunogenic tumour. It actually has a very low tumour mutational burden, and unlike clear cell kidney cancer, doesn't have a strong immune infiltrate. And so it does seem strange that we've been using VEGF-targeted therapy and immune checkpoint inhibition, particularly VEGF-targeted therapy in this setting. Therefore, I was surprised to see that when we use the combination of immune checkpoint inhibition and VEGF-targeted therapy in papillary renal cancer, we saw higher response rates than expected. Cabo-Atezo frontline response rates of 47%. You might remember that single-agent sunitinib has response rates in the region of 5%, and even Cabo is only 20%. And then Cabo-Nivo, again, 47% response rates. Bev-Atezo even has response rates which are respectable, certainly compared to sunitinib, and lenvatinib and pembrolizumab, higher response rate still. So overall, I think it's very reasonable to say this papillary cohort has shown these combinations are more active than we thought initially. And the combination therapies, I think, now need to be considered as a standard of care in this setting, although it is reasonable to say there's a lack of randomized data, and therefore the level of evidence remains weak. But in this area of unmet need, when response rates of over 40% can be achieved, that seems preferential to sunitinib, for example, which has response rates of in the single digits. Neil, there's a question.
What about Ipi-Nivo in those patients?
Yeah, so there's been a bit of work with Ipi-Nivo. The data doesn't look as impressive as the VEGF-TKI-IO combinations. You might come back and say, hold on a second, Tom, you're comparing 30 patients in one trial and 20 patients in another study. You're absolutely right. There is a study coming out called Sunny Forecast. That is a randomized phase 3 trial, which is now complete, of Ipi-Nivo versus sunitinib as a randomized phase 3 trial in papillary renal cancer. So we're going to learn a lot about Ipi-Nivo in the future. At the moment, the response rates don't look quite as high, but I think it would be premature to say Ipi-Nivo's not active in this setting. I've got a very quick summary slide that I was going to run past you. The first is an observation from my perspective. We've reached a bit of a plateau in drug development in kidney cancer. Actually, we did this about a year ago. We've seen a number of drugs coming through, a number of new targets coming through, which have been disappointing. Pegylated IL-2, for example, some of the arginase inhibitors, some of the glutaminase inhibitors. Some of the newer targets have not been successful in this space. And indeed, a second generation of immune therapies, OX40, LAG3, TIGIT, other targets haven't reached prominence and may not reach prominence in this space. Under those circumstances, we currently have VEGF targeted therapy. Belzutifan is a new part in that armory, which inhibits HIF2 alpha, which we hope will be approved from randomized trials relatively soon. But we also need to consider, with this plateau, what the next major steps in kidney cancer are. I'm going to talk about that in a second. I think there's also reasonable debate around the treatment of good risk disease and the role of VEGF-TKI and CTLA-4 in combination with PD-1 in the frontline setting. There are some people who feel ipi-nivo is the best treatment. There are other people who feel you have to get in control with VEGF-TKI IO combinations. I hope I've explained to you today that actually in terms of the long-term data, there are more similarities than differences between these four regimes. I still believe that VEGF-TKI IO therapy has higher response rates and is better at getting in control of disease. But I do think at the same time that COSMIC 313 data does question the role of VEGF-targeted therapy in poor risk disease. Again, it's important to say that's exploratory and underpowered analysis. And this is an area which the debate will intensify over the next 6 to 12 months. The VEGF-TKIs are very similar. This is particularly true when we sequence them after initial therapy. I'm very open-minded about second-line therapy, and axitinib, cabozantinib, tivozanib all to me seem reasonable treatments. I think the real skill in kidney cancer is not the choice of drugs, but how you give the drugs and the support team around that. HIF2 alpha belzutifan is the most attractive new target. The biomarker data appears confusing. There was actually some very nice circulating biomarker data at ASCO GU 23. I think we're going to end up using circulating biomarkers in kidney cancer in the near future. As I said before, new combinations, and I showed you some data with belzutifan, do appear promising, although the COSMIC 313 trial showed us that triplets are not necessarily a home run at this stage, and we need to see overall survival before we go further. The last thing is in papillary renal cancer, there has been a drift towards these doublets. That drift is based off single-arm trials, a lack of randomized data. I'd love to see some randomized data in this setting, and Sunny Forecast will be the first of those randomized trials.
A couple of follow-up questions. What about patients who have non-clear cell, non-papillary? How do you approach them?
So I think there was one subset of that which is really important, and that's the sarcomatoid tumors. Some patients have mainly clear cell with a component of sarcomatoid, others pure sarcomatoid. These patients must have immune checkpoint inhibition. And I don't mind if it's ipi-nivo or VEGF-TKI-IO. These drugs are transformative for these patients. And I have a room full of sarcomatoid patients who we've now cured, who 10 years ago we gave drugs like sunitinib and they faded away within months. So transformative in that subgroup. There are other aggressive tumors, Bernini tumors. We're still using chemotherapy in those tumors. Other chromophobe, advanced metastatic chromophobes that we're treating in a similar manner. Essentially, we haven't done enough trials on this group of patients. One thing I can tell you is the Checkmate 427 trial looking at pembrolizumab in the chromophobe tumors didn't show a spectacular benefit. So I'm not sure immune checkpoint inhibition is the way forward in advanced chromophobe cancers.
Another question is, any clinical situation where you think you'd like to use a triplet like COSMIC?
I think we need to wait for an overall survival signal. I really do. I think that there may be groups we'd like to see in the future. I think if you went back and you pulled, someone off the street and said, who did we think with hindsight they'd be important in? I think many people would say it's those really poorest patients with rapidly progressive liver metastasis. Get early control. But actually in those poorest patients, there didn't seem to be that benefit. I still firmly believe that the combinations like len-pen, particularly with bone and liver disease, getting that control is really important. And it's my preference to give those patients len-pen rather than ipi-nivo. Although, as I said before, it is reasonable to come back and say in those poorest patients, perhaps immune therapy is more important. I agree with that. The final point I'd like to make in that is these are exploratory analysis. And we know from the prospective randomized trials that Axipembro, Len-Pen, and Cabo-Nivo all perform well in porous disease. And therefore, it's premature to say Ipi-Nivo is the right treatment for these patients.
Do you know whether in any cancer, but including renal cell, people have looked at ctDNA in patients who've been on, a couple years of IO, just to see what it shows?
So yeah, the answer to that question is simple, is we haven't yet nailed this circulating biomarker question. There are some methylation signatures, which I think are more promising than the DNA signatures. And there was a nice piece of work in Nature Medicine 2 years ago regarding that. But I would say at ASCO GU23, we did see some really neat circulating biomarker data. And actually, we saw 70% of patients were ctDNA positive using a personalized approach. That was twice as high as I was expecting. And Neil, this is important because there's going to be a transformation in cancer. In key cancers, the technology for circulating biomarkers is moving extremely quickly and is really promising.
What do you think you're going to see in these, tumor-informed ctDNA assays in these people who go out a couple years on IO therapy, either those who are clinically in CR, or then sometimes you sort of see stuff and you don't know whether it's active disease? What do you think you'll see with ctDNA?
So I think what we're going to see is ctDNA clearance. And I think what I'd like to do is prospective studies where at ctDNA clearance, we stop therapy. Because at the moment, it's really unappealing. I saw a patient yesterday who said, how long am I going to be on this treatment for? We were starting VEGF TKI, and I said, well, maybe forever. At the moment, we're not stopping these drugs. And he said to me, well, that's not a great goal for me. People's aspirations 5 years ago, just give me anything, because the survival was a year when we started doing this. It's now 5 years, which is terrific. But now I've got patients coming and saying it's not good enough just to be on treatment forever. I need to be free of treatment at some point. Otherwise, I'm not achieving my goals.